Hey everyone, I'm Mariana Parks, physical therapist, and today I interview Dr. Julia Treleaven, and she's going to talk about the role of the neck in the sensorimotor control. Dr. Treleaven is a senior researcher and lecturer at the University of Queensland. She has been researching whiplash and neck pain since 2000, with over 120 publications in this area, and in 2004 she completed her PhD on the neck's influence on sensorimotor control. In our discussion today, you are going to learn about what sensorimotor disturbances in the neck are, and how to assess and manage them, and how they happen, and the importance of adding sensorimotor control training to a conventional neck treatment. So if you feel this information is valuable, please consider subscribing to our channel, clicking on the bell so you don't miss anything, give us a thumbs up, and share with other clinicians you think might benefit from this information. I hope you enjoyed the show. PT Pro Talk podcast is only possible with the support of the forward-looking and innovative companies like Systems for PT, the Do Anything, Anytime EMR. Systems for PT develops systems for clinics so you can focus on your patients. Go to systemsforpt.com to schedule a demo today.
Fitter First, your first choice for the best Canadian-made rehab and fitness products since 1985.
Hi Julia, welcome to PT Pro Talk. How are you today?
I'm well, thanks for having me.
Awesome. So let's get started. Just telling us a little bit about your background.
So I've been a physio for quite a few years now. I started off working in a public hospital across different areas of the hospital that included outpatients and brain injury and spinal cord injury and things like that. And then I became a clinical tutor in outpatients working for the university. And then that sort of started my journey into starting into some research. We were looking at trying to develop some research into whiplash, and then that turned into me doing a PhD in that area. And that's where my interest in sensorimotor control sort of started, because we were finding that a lot of people with whiplash were reporting dizziness and visual disturbances. And so we wanted to look into that a little bit more. And that was part of my PhD. And then since then, we've sort of been continuing on with that area of research, looking into headache, concussion, into the elderly and that sort of thing. So really trying to being able to work out when the neck has a role to play in headache and dizziness and things like that.
That's awesome. And we are going to talk today specifically about the sensorimotor disturbance on the neck, right? So let's just start talking about what are these disturbances and how do they happen?
Yeah, so basically sensorimotor control refers to the system where input from the proprioceptive system, the visual system and the vestibular system come into the brain and become sort of tuned and integrated to provide motor output for eye and head movement control and postural stability. But we know with the proprioceptive part, the neck is really important because it has really high numbers of muscle spindles in the muscles, particularly in the suboccipital muscles. It also has reflex connections between the neck and the eyes and the neck and the vestibular system. And it also has, lots of sort of unique connections to the brain that other areas don't have. So the neck is a really important aspect for that. So it can so when the afferents are affected, then that can affect head and eye movement control and postural stability because the brain is not getting all of the information correctly.
And how they usually happen? So like if you have a muscle strain or if you have a trauma, like which situations do you see that happening?
Yeah, so we see it in a lot of people with neck pain, regardless of whether they've had trauma, but we certainly see that it's more common in people with trauma and more extensive in people with trauma. And that's probably because there's more structures that are potentially, affected during a traumatic event where you might have muscles and joints and other structures. So, but we certainly can still see it in people who have, just non-traumatic neck pain as well. But it's, probably relating to, that sort of pattern of dysfunction that we see in people who have a neck problem where, their muscles become inhibited, they've got joint signs, that sort of thing.
And do you feel like that is common? Do you feel like it's most people that have neck pain that have this disturbance?
Yeah, so probably not everybody, that's for sure, but certainly people who have had trauma, then you should look for it. If they're complaining of dizziness, then definitely should, or visual disturbances, then you definitely should look for it. And if they've got an upper cervical problem more so than a lower cervical, then you should also look for it, because that's where, a lot of those muscle spindles are. So therefore, if those joints are affected, then that could potentially affect those muscles. Having said that, so, I tend not to look at it if someone has more a lower cervical problem, but if they're not progressing the way that I think they should be with exercise and manual therapy, then I will also check sensorimotor control to make sure that they haven't got it. And sometimes people do. Sometimes people surprise me. Other times people have an upper cervical headache and they don't have any sensorimotor. So, but I think definitely if they've had trauma, they're complaining of dizziness, then that's a definite. And then the others you should, check if things are not progressing the way they should be.
So do you feel like if they have a problem with the sensorimotor system, it would prevent them from recovering well in the normal neck rehab, like with range of motion, strength, and all of that?
Yeah. So some patients, I think, don't need specific sensorimotor control training necessarily. We know that things like manual therapy and training the deep neck muscles can improve things like joint position error and balance and things. But there's also been a recent clinical trial that I was involved in, which was done in Thailand, where they had people who had non-traumatic neck pain who did have a balance or a joint position error deficit, and they had groups of patients. So one group just had manual therapy and exercise. The other groups had that plus joint position error or plus balance or both. And all of the groups improved in their neck pain and disability after the trial. But what was interesting was that if you wanted to improve joint position error and balance, then that group that had those things added did a little bit better. And the other thing that was really interesting was that at the 12-month follow-up, the people who had the additional sensorimotor training had a better outcome with respect to maintaining an improvement in their neck disability. So maybe that when somebody has a problem, adding that in might be a good thing in the long term.
That's interesting. So that would prevent recurrence.
Maybe, yeah.
And do you have any theory why?
I think, because what can happen is the afferent input has become impaired, and at that basic level where, we're addressing the muscles and the joints and the things that are causing that afferent input and pain, then we can sort of, often we can help. But if then that information and the talking between the neck and the eyes and the vestibular system has now become a bit impaired, then maybe that's when we start to need to add that sensorimotor control training, because basically it is really addressing, making all the systems talk to one another again and recalibrate.
Yeah, very interesting. And how do you assess that in a patient?
Yeah, so there's a few things, and I guess it depends on what they're coming in for. So if it's just a neck pain patient, and you're just wanting to screen or check for sensorimotor control, then I would look at joint position error and movement sense as a first thing. Then you can look at coordination. So there's eye-head coordination and trunk-head coordination. And then we can look at gaze stabilization. So lying and moving the head, seeing if the gaze can stay stable. And then the final one would be the smooth pursuit neck torsion test. So adding neck torsion once you've looked at smooth pursuit in neutral and looking at it in torsion to see if it gets worse in that torsion position. And then the other thing is you could quickly check balance as well. So it sounds like a lot of things, but actually once you get going, it's quite quick to check these things. They're quick and easy tests. The movement sense and joint position error require some equipment, but everything else doesn't require any equipment and can be done quite quickly.
That's what I was going to ask you about the cervical joint position. I read that you had like a headband and then like a laser light or something like that you can like measure the. So how would you do that if you don't have that equipment? Is there a way that we can implement that?
Yeah, so if you don't have that equipment, you could do something like get the patient to look into the mirror, put a little blob of toothpaste on their nose where it lines up, and then you could just get them to close their eyes, come back, try and come back to that center point, and then you could reposition them, and you could sort of check the distance between that where they came back to and where the starting point was. So that you could do that. You could measure it. We use degrees, so 4.5 degrees is considered abnormal. Outside of that, it's considered abnormal. So if you were doing that, then what you would need to do is make sure the patient or the patient's nose is 90 centimeters away from the mirror, and then you can, if it's 7.1 centimeters, then that converts to 4.5 degrees.
Very interesting. And I think once you're familiar with the tests, I bet you can go through them really quickly with the patient. But I just don't feel like we are used to assess those things with the normal neck patient, right? What would be like your tip that we can implement those tests like in the assessment?
Yeah, so I think what you should probably do is just, pick one or two and start doing that with all of your neck pain patients, just, so that you get comfortable with that test, and then you can add the others in. So you could do, for example, the trunk head coordination, which is a good that one because it tells you lots of information. So it's just asking the patient to look in front of the mirror, try and keep their head still, and then they try and turn their trunk while they keep their head still. And when I do that in standing, and you can see whether can they do that to the left and to the right. And often they can't. Often they cannot keep the head still. The head wants to go around with the neck. And then you could do the 𝗓𝗄𝗂𝐴 neck torsion test, which basically is, moving your finger at about 20 degrees per second. So it should take you about 2 seconds to go from one side to the other. And you're watching to see if they're getting these sort of quick little catch-up saccades with their eyes. And then you do that in neutral. Then you turn the patient, keep the head still, and they rotate the trunk and shoulders, and then you repeat that each side. And so that could be maybe those two things just to start with. And if you don't have any equipment, or you could also do that joint position error one, because often if they have joint position error problems, then you might find other problems. So maybe that's the one to sort of kind of focus on as well.
And would you screen these in all patients, or is there any symptoms that would get your attention to test these things a little bit more in detail?
Yeah, so definitely, as I said before, if they're complaining of any dizziness or unsteadiness, some visual disturbances, if they've had trauma, so if they're a whiplash patient, then I would do it maybe not on the first day, depending on how many other problems they have. If it was a whiplash patient that my main problem was neck and arm pain, then it wouldn't be my focus on the first day, but I certainly would be checking it. But certainly anyone who's coming in complaining of any sort of unsteadiness and visual disturbances, then I would definitely be assessing it on the first day.
Okay, and then let's say you assess them and you found some things. So how would you manage these disturbances?
Yeah, so as we mentioned before, you can do your usual treatment, and you should do your usual treatment. So things like manual therapy and specific exercise for the neck muscles. But then again, for the sensorimotor, then you just treat what they can't do. So if you find that they have a joint position error when they turn their head to the right, then that's what you would get them to practice at home. And they can practice that by doing, for example, closing their eyes, turning their head, coming back to the center, opening their eyes, check to see where they are, and then reposition their head back. So, that you could do that. If they've got a problem with their balance, that's what they would practice, trying to hold that position for 30 seconds. If they've got a problem with, being able to keep the head still while they move the trunk, then that's what they would practice. So it's more about where you might start, so what position you might put them in. So you might start in sitting, or sometimes you can progress them into doing, for example, joint position error in a balance task. That's a more advanced thing to do. The speed and those sorts of things are things that you can change to make it harder.
Okay, so you would basically be asking them to repeat that activity or movement that they're having trouble performing as the treatment, and then progress depending on the task with the eyes open, eyes closed, unstable surfaces, and that type of things.
Yeah, definitely. Yeah.
It just sounds more complicated than probably what it is in the practical terms and when you're treating patients, right?
Yeah, that's right. Yeah. And I think, again, it's just maybe, picking a couple of things and making sure you do that every time with every patient. And then when you start picking things up, and then you can add another test to it and another test sort of thing. But it is quite quick to do.
Yeah. And you can just go slowly adding those until you find something that you need to treat, and then add those to the treatment. And so what is the importance of adding those things to your normal neck treatment?
Yeah, so I think in some patients, it's what is really needed for them to move forward. So I've had a couple of, I tend to get lots of patients who've already had lots of physiotherapy, lots of manual therapy. They've had even quite good neck-specific exercises and that sort of thing, but they're still having problems with, dizziness or sometimes headaches and things. And then when we add the sensorimotor things to it, that seems to be the thing that really helps them to progress. And as we were talking about before, maybe it can be helpful with respect to prevention as well. So I think that's important. The other group that we haven't talked about is people who've had a concussion as well, because, but then, often then we're talking about differential diagnosis and what is the role of the neck in some of these symptoms that they have, things like dizziness. And so the sensorimotor assessment can be really helpful. And also patients with vestibular problems, who have neck pain. A lot of those patients have neck pain as well. And so then it's working out, how much is the neck involved in this patient's presentation. So that's where you might need a few more tests to add in to sort of help differentiate, is it vestibular or is it not? Is it more neck? That sort of thing.
Well, since you start talking about it, how would you differentiate that dizziness that's coming from the neck or not?
Yeah, so I think we probably have to be careful about sort of trying to diagnose it these days, because there's so many things that the neck could be as part of the role of it. Okay, so it could be, yes, the neck is causing all of the dizziness and we just treat that and we'll get rid of it. It could be that the person has had a concussion, for example, and they've got some neck pain, but they've got dizziness that's completely separate, and that's from vestibular or visual problems. It could be secondary. So they might have a visual problem that's now causing a neck problem. So there's lots of, potential roles of the neck, but I think we can use some tests to help us work out how much the neck is coming into play. Okay, so that might be a really good assessment of the neck. So we should see a good pattern of musculoskeletal disorder, so that, they should have positive joint signs. They should have poor muscle control, maybe altered movement patterns, that sort of thing. Then in terms of trying to work out, is it more neck or more vestibular? So things like the smooth pursuit neck torsion test, for example. So if their smooth pursuit in neutral is terrible, and then when you put them in torsion, it's just as terrible, then it's probably not the neck influencing at all. Okay. But if it's worse, then it might indicate that the neck is involved. The other thing is things like eyes closed and doing, a rotation on block. So in that position, we're not moving the neck, but we're moving the vestibular system. So if that's causing dizziness, but then when you do it, keeping the head still and rotate the trunk, that doesn't cause dizziness, then that's making you think, okay, that's more vestibular, because I've messed with the vestibular afferents on the first one, but on the second one, I'm messing with the neck, but not the vestibular system. So little things like that can help you to sort of make your mind up, but it should be a pattern. So it should be, all of the tests adding up so that at the end of the assessment, you can say, okay, I really think that the neck has got a major role here, or no, I think the neck has got a partial role, but I think there's another cause of dizziness or there's two types or that sort of thing. So, so that side of it can get a little bit more complicated if you haven't been, even not looking at sensory motor control in people with neck pain. But I think that's, that's somewhere where it can go to really be helping us to differentiate the role of the neck when in people who've had concussion or whiplash or, and also other patients with vestibular problems.
Very interesting. A lot of new information there to unpack. So when you say that the dizziness could come from like some problem visual, right? Those exercises that you were mentioned before, like with the sensory motor control, is that could be helpful in that situations, or you are just treating that cause that's coming from the neck? I don't know if it makes sense, my question.
No, so yes, I know what you mean. Yes, no, so definitely because the exercises are doing things like moving the neck and the eyes together, it can potentially help. So if you're not sure, then maybe starting these exercises is fine to do, because even in a vestibular patient, if they've got lots of neck pain, they're not going to be able to do the really, difficult vestibular rehab exercises where they have to move their head quickly and lots of repetitions. So this sort of thing could potentially help because it's starting to integrate things. But then what you should do is, as everything's getting better and their performance is getting better, are their symptoms improving? And if they are, then that's great and you can keep going. If they're not, or if there's still some, then maybe that's time to refer on to the vestibular physios or to a behavioural optometrist or something like that, depending on what you think is the cause.
Yeah. So, like, for example, physios like me, I don't know much about vestibular rehab, as you can probably tell. So I usually treat a lot of necks. So, like, when do you, do you know that, okay, all of this dizziness and some headaches are coming from the neck? So you try to treat these sensory motor control disturbances, and then if they don't get better and you still have those symptoms, then you would refer to like a vestibular rehab therapist? How would you differentiate that? Yeah.
Yeah. So, if they had true neck, you found things on the neck that you could treat, then you could trial that treatment first. If, though, you've assessed them and really they don't have very much wrong with their neck and they've got all these symptoms, and particularly that's similar in headache as well, it doesn't add up. And so then maybe it's time to refer on to somebody else who might be able to help the patient more.
Yeah, absolutely. And then when you talk about whiplash, how is that related to the dizziness, those headaches, and how do you differentiate and identify to be able to refer them out or treat them yourself?
Yeah, so again, with whiplash, most people have got a neck disorder as part of the whiplash. So for those patients, then you would be treating their neck anyway for their neck disorder, and then also then seeing whether or not you think, is the headache changing, is the dizziness changing, adding some sensory motor control, but really, monitoring it carefully. And if the neck is improving and the muscle control is improving, everything's improving in the neck, but their headache is not changing or the dizziness is not changing, then that's time to refer on to, say, a neurologist for the headache or vestibular physio for the dizziness. So it's really making sure that you're being very objective and, noticing, is your treatment helping these other symptoms? If not, then it's time to move on. And also, does it make sense? So, for example, if someone has got, 8 out of 10 constant daily headache and all you can find in the neck is a little bit of, mild dysfunction at the C1-2 and most of their neck pain you think is coming from lower cervical, then that doesn't add up. it doesn't add up that that could be causing that kind of a headache. And so I would probably be referring them on much quicker, but still treat their neck because they've still got a problem with their neck, but be referring them on and getting better help for that headache because, they can't have that kind of headache and only have mild dysfunction in the upper cervical spine.
Yeah, it makes sense. So let's say you are getting a patient that has neck pain. So you would treat, like you were talking about that paper that you separated in groups. So you would recommend this multimodal approach, treating the neck as usually most people are used to treat the neck, and then add those like balance exercises and then the sensory motor control activities.
Yeah. So definitely. Yeah.
And add all of those to treat like more trying to get all the different aspects of the rehab.
Yeah, so definitely a multimodal approach. We know that that's the evidence is there that that's the best way, and with the sensory motor, it should be tailored to the patient. So you wouldn't give them balance exercises if their balance is fine. You wouldn't give them joint position error exercises if they've got good joint position error. But whatever you find in the assessment that they can't do, and that's where you would target.
Yeah, good. And for the people that are listening to us, there was a paper really good that you sent me, so I had the chance to take a look, that you describe really well all the tests and how to perform them, that I think was really helpful. So I'm going to put that link on the show notes so people can go check. And as you said, it's very quickly and easy. And you have like the pictures to help us identify how is the test and per consequence, how you're going to treat them. So that was very helpful. And I don't know if you have any comments or any observations about those tests that you want to talk in particular, but for me, at least, that was very helpful to make it easier to just understand when you have like those examples and pictures.
Yeah. Yep. So that was written quite a few years ago now in 2008, but it still has, there's probably some tweaks that we've made to some of the tests, but that's fine. We also have our book, Management of Neck Disorders, an evidence-based approach. So that was published in 2018, I think. And that has a chapter on sensory motor control with pictures as well. So that's probably the most updated version if people are interested. It also has a chapter on assessment and treatment, and then it has some case studies where you can read how we would sort of integrate some of this kind of stuff in a patient.
Very good. Before we transition to our final questions, do you have anything else that you want to mention about the topic? Anything that we haven't talked about that you want to wrap up?
Yeah, I just think with sensory motor control, we also know that in some trials where they've just done exercises relating to sensory motor control and haven't actually treated the neck in the traditional way, that it has improved neck pain and disability. So it's kind of another thing that we have at our disposal to use. And if you've got a patient who can't manage manual therapy because they're sensitized or whatever, they're having difficulty with exercises. Some of these exercises are quite simple. And so maybe it's another thing that you could add in to your patients, particularly those difficult patients where you're sort of having trouble doing other things. And you can always, give a balance exercise or an eye exercise. You might have to do it lying down, for example, but, that's important. And the other thing is, I think, just try and think about using the connections between the eyes and the ears and the neck to your advantage. So it might be, if you're trying to get better range of motion, then maybe getting them to look first and then turn, because that's going to help facilitate that. Or some patients, they're actually better if they try and focus and then they turn, they get better movement. So just have a try. And we know for things like craniocervical flexors, for example, we use vision to help as a cue. So they look down to nod and that helps to facilitate those muscles. So I think just trying to use, think about the importance of those connections and use them to your advantage.
Yeah, I think it's a good option to consider that I feel like many times we don't think about we don't know about. We just do very traditional physical therapy, manual therapy, and it looks like such a good tool to improve our treatment. And as you said, especially in these acute cases, I would not think about it. So I think it was a really good point. Very good. So let's transition to the final questions. Any resource of information that you like in particular that you would recommend our listeners to go to?
Yeah, so I think our book that we did in 2018 is a really good book for neck disorders in general. So it covers all the assessment for motor control with pictures, sensory motor control. It has a chapter on nerve function, and then it has case studies as well. So I think that's a good resource for people who are wanting to get a evidence-based approach to neck pain that's, based on research, but also has a very clinical focus as well.
Good. And what would be the best advice that you give to clinicians that are starting their careers?
So I think always try and clinical reason is within your capacity. Try and make does this make sense? Does this patient in front of you and what they're presenting with, does it make sense to you? And try and make sense of it if it doesn't make sense. So it might be that you've missed something. Maybe you need to look at something else. It might be that there's an area of knowledge that you don't have that maybe you need to seek out. I think just always trying to make sense of it so that then you're growing and you're learning because that's the fun part of physio, is working out what's going on in patients so that you can get the best outcome.
Absolutely. And what personal qualities or abilities that you think are important to become a successful PT?
Yes, I think you have to have good clinical reasoning. You have to be able to work out what's going on. You have to be able to try and work out the main problem and what's contributing. What do you need to focus on the most first, and then what's coming in after that. I think also just being able to have good rapport with your patients and be able to, get good adherence with exercise, because we know that we can do manual therapy on people, but if they don't go home and they don't do their exercises, then we're not going to get the benefits that we're looking for. So being able to demonstrate to patients why exercise is important, why they need to do their home program, those sorts of things, I think is important as well.
And you were just mentioning about home exercise program. I was curious to ask you, so if these exercises help to prevent recurrence, I imagine you probably send the patients home doing those exercises. Is that right? Or how would it work with your patient? Would send them home with the other maybe exercises for range of motion or strengthening, and then those exercises as well?
Definitely. I mean, that's how they do their exercises. Just doing them in physio would not be enough. They need to do them sort of, each day and that sort of thing. And then in terms of recurrence and prevention, we don't really have the evidence for that. How much do we need to do? But maybe in some patients, they might be where they have to do something each day or something at least a few times a week just to prevent things from coming back. And so then, what that looks like, it might be that they're doing posture correction, that, maybe once a week they're checking their joint position error. We don't know, but certainly probably things like a posture correction, because we know that activates a lot of those stabilizing muscles. Maybe that's enough, but yeah, we don't have the evidence for that yet. But I certainly see patients who, particularly the ones who've had trauma, if they stop all their exercises, and about 6 months later they come back because now their symptoms have started up again. And whereas others, they're fine; they don't need to do anything.
Okay, sounds good. And Julia, if people want to know more about you, your work, or your research, how they can find more information?
Yeah, so at the University of Queensland, so you can go onto that website and you can search for my name, and my research profile and all that sort of thing will come up. But I'm also on Twitter at julia.treleaven. So if people are interested, I usually try and put things up, like new papers that we've published, that sort of thing, so that, people can keep up to date with what's going on.
Very good. Well, thank you so much for taking the time and share all this good information with us and gives us this new perspective about the neck treatment. So I appreciate your time. Thank you so much.
Oh, thanks so much for having me.